virtual rounds. There you go. So we're officially online. I'm really honored to have such a great panel and also such a great turnout for tonight, kicking off, a topic that is ubiquitous with trauma and damage control, polytrauma, fracture care, mobility. These are concepts that all orthopedic surgeons need to know and have a good handle on. But it's going to be great to hear from the experts we have who are synonymous with the terms that we think of when we think of damage control and polytrauma. So I just want to start by introducing the panel that we have, and it's awesome to see Dr. Pape was able to join us here. And so we have. Starting from the top of the slide that you have there, we have Dr. Hans Kreder from University of Toronto, and Professor Pape from University of Zurich, joining us all the way from Switzerland at 1 a.m. Hopefully he's got some coffee and is ready to go, but we'll try to keep the discussion lively to keep him awake and engaged, and I'm sure he will keep everybody on their seat's edge. We got Professor Niloofar from the University of Arizona, and a COTS icon, really, and we'll talk a little bit more about her shortly. And Professor Paul Engels as well from McMaster University, providing our multidisciplinary component tonight as he covers surgical, general surgery trauma as well as ICU. So I'm just getting all kinds of beeps going. Oh, I think I just have to officially accept there. So I mentioned tonight is the first of our series, and it's a joint venture with Mac Ortho Trauma and COTS, as well as really the international orthopedic trauma community. And we have a series coming up for the next several weeks, covering lots of different aspects of trauma care and orthopedic trauma care. And you'll be hearing a lot more about those as we carry on with our series and continue to keep you informed. We're going to have some excellent panelists throughout, and hopefully we just get a growing number of you joining in to help with to get the discussion going along. So I'm going to go through my brief introduction here, and then we're going to hear from Professor Kreder on really the concepts around orthopedic trauma in Canada and how it's evolved and where and where it's been and where it's going to go. The challenges for caring of polytrauma fracture patients is going to be covered by Dr. Engels. We're going to hear from the name synonymous with damage control orthopedics, Professor Hans Pape and Hans-Christoph Pape, and then Dr. Niloofar Dehghan is going to talk to us about the role of rib fixation, and the role of mobility in polytrauma patients is going to be covered by Professor Kreder, and then we're going to open up the discussion to some controversial concepts and some cases. Reminder, tonight's event is recorded, and as we're having our presenters go, just hit mute and keep your video off so we can have an engaging lecture, and then afterwards, when you hit the discussion, just unmute and turn your videos on. You can unmute and just voice your question as we go through them, or raise a hand and ask a question or ask a question through the chat, and I'll try to keep an eye on that. And the full recordings of the session is going to be available subsequently, and as we're going to as we finish, we're going to upload them onto our website, and you'll all be able to go through them at your own leisure. So as a brief introduction, I'm Herman Johal, Director of Orthopedic Trauma at McMaster Orthopaedics. Work at the Hamilton General Hospital, which is level 1 trauma center, and also work with the Center for Evidence-Based Orthopedics as one of the clinical scientists. I'm trying to slog through a PhD for some reason. Someday maybe I'll finish it. And the whole reason we're doing this is, the world has changed now, and we just were talking about it before we got started. The corona pandemic has really, by just the very nature of what we're dealing with, changed what we do in orthopedics with respect to how we congregate, how we exchange ideas, and we're moving away from the traditional podiums to what we've really been able to engage in multiple lecture series now at MacOrtho, and to virtual engagement and networking. We can discuss concepts across the country, across borders, around the world, and that's really exciting. And we started a lecture series, a virtual lecture series with foot and ankle, as well as arthroplasty and sports at McMaster. And now, one of our residents, actually Dan Axelrod, who's on tonight, was instrumental in setting this up and getting the motivation behind the different groups involved. And when it came to trauma, we figured, why stop at just one speaker? Let's get a whole panel going and talking about interesting concepts and ideas as we care for our trauma patients. And the initial network we reached out to was our Canadian Orthopaedic Trauma Society, which we'll hear a little bit more about, hopefully, from Dr. Kreder. And that gave us access to the world of orthopedics. And we continue to engage our panelists who are going to be amazing as the series goes on. But what we're going to do is going to bring that panel here tonight to talk about some concepts in care. We're going to start with, we're going to have Dr. Paul Engels, after a brief introduction by Dr. Kreder, talk to us about concepts in care for the polytrauma fracture patient. As mentioned, he's on the trauma he's on the trauma team. He's a trauma team leader and works in ICU. He's done his fellowships after training initially at University of Alberta. He did a fellowship in trauma care at the University of Toronto, and he's been instrumental in the Trauma Association of Canada. And so I want to actually, I'll have him go after Dr. Kreder, who is the Chief of Orthopaedics at Sunnybrook Health Sciences at the University of Toronto. And he is the first Marvin Tile Chair of Orthopaedics at the University of Toronto, and has been one of the members of COTS from the ground up, and performed many randomized controlled trials in orthopedic care, and covers everything from pelvis, femur fracture, arthroplasty. But we're going to have him talk about how we get people moving following trauma. And so we're going to start with actually Professor Kreder, and I'm going to turn the screen over to him to talk to us a little bit about Canadian orthopedics and trauma care.
All right. Well, thanks, Herman. Just so you know, I finished my stint as the chief of orthopedics, so I'm no longer that. I don't have to do all those meetings, and I finished just before COVID started, which was perfect timing on my part, because I wouldn't want to be in Albert Yee's shoes, who's the current chief. Can you see my screen okay there?
Yep.
Okay, great. So these are my disclosures, as we're all asked to do. And what I've been asked to talk to you about is an evolution of trauma care from a Canadian orthopedic surgery perspective. And I see this mainly as just a description of trauma care systems in Canada and some of the challenges, and historical concepts of fracture management in the multiply injured patient. And that's really a setup for Dr. Pape's and Dr. Engels' talks to come. So I won't go into that in any great detail. So in 1966, the US National Academy of Science thought that accidental death and disability was a neglected disease and that something should be done about it. And a decade later, 1976, what exciting things happened in the world? Well, Steve Jobs incorporated Apple. So Apple, the first Apple computers were 1976. And in Canada, the first trauma unit became named, and that was Sunnybrook. And Rob McMurtry, who you see there, was one of the founding members of the Trauma Association of Canada. And Marvin Tile, of course, was instrumental in the trauma unit and was chief of orthopedics, chief of surgery, and held many other positions in Sunnybrook and beyond. And the paramedic program in Canada started in terms of training the following year in 1977, and they were fully operational by 1984. And what that meant was that the doctors didn't go out in the front lines anymore. And that actually was shown to be a really good thing, because the paramedics were trained in the field and the doctors really were out of their element to some degree in the front lines. And we developed a regionalized transport system for trauma in the country. Now, in Canada, healthcare is a provincial jurisdiction, as most of the people on the panel will know, and Hans-Christoph will know that as well. But In Ontario, our fleet of paramedic vehicles is 8 airplanes, 12 helicopters, and 13 ambulances. And if you are interested, you can log into the website and see the statistics. This is Sunday, April 4th, of how many transports they do in a particular day. And it's quite a lot. So, you know, the paramedics are busy. This is the Trauma Association of Canada website. And you'll see that they've got a meeting coming up, and I'm sure Dr. Engels will probably be participating in that. But their first meeting was in Calgary in 1983, and Bob McMurtry, who ended up at Sunnybrook, was at that inaugural meeting. And this is a federal organization, and again, with the jurisdictions being provincial, what they do is look at statistics across the country and try to improve trauma care across the entire country. So what this graph shows is, for example, the blue bars show anybody who is within 1 hour catchment area of a trauma center, and the red bars are anybody outside. So in Quebec, almost the entire population is within 1 hour of a trauma center. But unfortunately, in Newfoundland, over half the population is outside of that 1 hour sort of catchment time. And on average, about 77.5% of Canadians are within that 1 hour, but nobody at all in Labrador is within even 2 hours. Most of them are 4 hours to a trauma center. So you can see some of the challenges that we have in Canada in getting multiply injured patients looked after. And, you know, what is the benefit of trauma centers? Well, lots of studies have looked at this over the years, and there is a reduction in preventable deaths, up to 25% in some studies. And it matters whether you get to a trauma center early or in a delayed fashion. And this is a study from our center from a number of years ago. And what they basically showed is that you're 1.25 times more likely to die if you should have been in a trauma hospital and you eventually get there, but you don't get there directly. And, you know, this is something that we're challenged with in Canada, unlike some of the other countries in Europe, for example, where everybody gets to a trauma center immediately. And switching over to the fracture care component of these multiply injured patients, we all know that long bone fractures can kill if they're not stabilized. And the question is, when should these and other fractures be fixed? Who decides? And, you know, you have to take into consideration the different perspectives of the different specialties involved. And this is a setup for the talks to come, but people say, well, you know, Larry Bone showed that, you know, early total care is the way to go, and that, you know, patients benefit from early care of their femur fractures. And Hans-Christoph Pape told us that damage control is important, that we shouldn't, you know, assault patients with additional trauma. And who do we believe? Well, the truth is that this has really come to be understood as a really a false dichotomy. It's a progression. There were different times. In 1980, when Larry Bone was facing weeks of delay in stabilizing femur fractures, you know, he showed with a couple of studies, including a trial in 1989, that if you neglect femur fractures for weeks, you know, that's a bad thing. And then in the 2000s, Hans-Christoph Pape told us that, look, if you're overly aggressive and fix everything, you know, the femur, the pelvis, the metacarpals, the pilons, right away, in some patients, you're causing more harm with a second hit. And this is the concept of damage control. And where does that come from? Well, in the US Navy, I'm given to understand that there are damage control officers, and their duty is to keep a damaged ship afloat, to fight fires, to prevent damage, and to educate the people on that ship about how to prevent and how to fight disasters. There's nothing about ignoring the damage and sleeping through it, which is what was happening in the 2010s in multiple centers, at least across North America. You know, there's the concept, just book this for tomorrow morning. Damage control means I don't need to get up anymore and do things in the middle of the night. This can all wait. Dr. Pape told me that I don't have to get up anymore. Well, you know, that's really not what damage control means. That's don't care as opposed to damage control. And this was getting to the point where, you know, we thought we actually had to look at this, and others did as well. And the bottom line is you need to show up, you need to clean wounds, and you need to stabilize bones provisionally or definitively, depending on the patient's status. And this is a paper from our center that showed, yes, in fact, it does matter if you delay treatment for certain high-grade tibia fractures, and you do need to come in and at least do something with those injuries. So in fracture care in the multiple trauma setting has been a progression of thought. And in the 1980s, we needed somebody to push to make sure that there weren't excessive delays, especially in long bone fractures. And in the 2000s, we got some tools from Hans-Christoph, Pape, and others that showed that, look, you know, you need to measure certain things to figure out who needs what. And those details are going to come in the talks to follow. And in the 2010s, our current emphasis is on a team approach, looking at all the parameters, all the measurements, and coming up with individualized fracture care, sort of a personalized approach to each person. And our CONTS group in Canada has been instrumental in trying to put together research protocols to try and study some of the details of these issues. The current thinking would be more along the lines of early appropriate care of fractures. And again, this team management requires good communication. And it's not the junior neurosurgical resident talking to the junior orthopedic resident. It's staff to staff. And it requires you to show up and to make decisions together. And we shouldn't forget about injury prevention. And there is actually a current push with various trauma prevention coalitions, because I can tell you that it's a lot easier to prevent this industrial accident that we had to deal with here some years ago than to deal with it after it's occurred. So the bottom line is you have some challenges in our Canadian system. We've tried to go over some of the historical concepts, and this is really in preparation for the talks to come that I'm very much looking forward to listening to. Thanks for your attention.
Thanks, Hans. That was wonderful, and I think that's a great introduction to the rest of the talks to come. I'm going to turn it over to Dr. Paul Engels now, and then sorry, his introduction was a little premature, but he's, as mentioned, one of our colleagues from the other side of the specialty pool, looking after these patients. So from ICU and critical care, I give you Dr. Paul Engels.
Okay, great. Thanks, Herman. Maybe just confirm you can see my screen and give me a thumbs up if you can hear me there.
Good to go.
Great. Well, thank you so much for inviting me to be a part of this illustrious panel. As Dr. Johal mentioned, I am a trauma surgeon and intensive care doctor that works at Hamilton General Hospital. Privilege of working with Herman. And I'll try to give you my perspective on some of these elements, which Dr. Kreder has actually very nicely introduced. And I think you'll see some recurring themes that we'll be building as we go through the talk tonight. Okay, so I always find that it's helpful to kind of think about the big picture, kind of just what Dr. Kreder alluded to. So for those of you that follow F1 or F2, you might remember this kind of picture, August 2019 at Spa and Belgium. There was a pretty bad crash on the Saturday F2 race. Two drivers, Hubert and Carrera, one lost his life. Unfortunately, the other one, Juan Manuel Carrera, who's there in the car on the right, suffered some pretty significant injuries. He ended up being transported to multiple hospitals and spent a pretty good portion of the next few weeks on ECMO, as well as multiple surgeries, and then obviously significant reconstruction, rehabilitation, etc. And overall, I was pretty pleased last week or a couple of weeks ago when we saw that he's now actually got back into an F3 car and is testing around the Red Bull Ring in Austria. And so this is a year and a half later, but this is really kind of why we're in the game and the business that we're in, to take someone with a horrific crash like that and put them all together and then get them back to doing what they're passionate about. So that's obviously what we're all here for to do, and really we're trying to think about how do we do that best and how can we do that as quickly as possible. So when I think of the management of these patients, I kind of have some goals in mind. Some of them can accomplish or be accomplished in parallel, and some of them are sequential and have to build on the others. The first thing, and I think it's really important to always keep in mind, is we need to stop the bleeding for these patients. And we can expand that to say that we need to identify and treat shock. But as we all know, a large proportion of these patients are going to be experiencing life-threatening hemorrhage when we're talking about the polytrauma patients. We know that hemorrhage is at least the second leading cause of death, if not the first, depending on how you want to slice the pie, with neurological injury being right up there. And it really is the biggest contributor to death, both in the pre-hospital phase, in the trauma bay, in the operating theater, and then in the ICU in that first 24 hours. And so we really need to think about what are we doing from a damage control perspective, from a total care perspective, from a resuscitation perspective to get that bleeding stopped. Assuming that we get the bleeding stopped, then we can kind of move on to the next phase. And we know that moving on to the next phase isn't as simple as just taking that person to the operating theater and operating until we've finished our part and then sending them back to the ICU. But we have to have some consideration for the patient's kind of physiological debt that they paid from that injury, and make sure that we return that account balance of physiology back to normal. And I think we'll probably talk a little bit more about this as we go on with the panel. But we need to get their physiology restored so they're able to tolerate more interventions, more surgery, and not just continue on. And as Dr. Kreder mentioned, there's this concept of damage control, which we often use, and did originate in the Navy. And the kind of one of the seminal papers that people often point to is Mike Rotundo and Dr. Schwab's paper in 1993, codifying this concept. But when you dig deeper, it actually was coming out in trauma surgeons in the early 80s out of Emory University, and some of this work by Dr. Moore when he was early in his career, recognizing that we can even stop bleeding, but those patients can still go on to have major problems with bleeding, even though it's not surgical. And the recognition that operating and keeping on going can be problematic, and identifying that restoring someone's physiology is actually equally as important to a good outcome. This is one of the classic diagrams back in 1982 of the lethal triad or vicious cycle. And you can see that it came out of a major abdominal vascular trauma, begetting hemorrhage, and then ongoing issues with hypoxia, hypothermia, acidosis, contributing to coagulopathy and begetting more hemorrhage. And I would add in here the soft tissue injury as well when I put up next to tissue hypoxia, because I think that's worth considering when we're thinking about how we stabilize a patient and how we restore their physiology. Because as Dr. Kreder showed with some nice slides there, having a mangled extremity that's kind of languishing there without stabilization, without hemorrhage control, is certainly not going to contribute to positively improving that patient's condition. And so hemorrhage control and tissue stabilization are going to be very important when we're talking about stopping the bleeding, as well as creating the conditions where we can restore the patient's physiology. And then once you've got that physiology restored, the next step is really to go on to definitive repair. And we'll hear more about that from the orthopedic and non-general surgeons on the panel. So I won't say too much more, but one of my favorite orthopedic surgeons always told me, if you can't plate it or nail it, screw it. And so I thought this nicely represents that. And really, we want to get to that definitive repair, whether that is, internal fixation or potentially external fixation that's definitive or near definitive, because we want to get on with early mobilization. And we know from the evolving literature and experience over the last 20 years in critical care that early mobilization is certainly valuable for our patients and speeds their recovery. In many instances, decreases the mortality rate, and is a cornerstone for getting them going, getting them returning to function better, and really even improving their outcomes. And then what about early mobilization in trauma patients? Well, I did have the privilege when I was a fellow back in Sunnybrook once upon a time to work with Dr. Kreder and some of the other excellent clinicians there. And we did look at the evidence that existed at that point in time, and it really was quite poor for trauma patients in the ICU, although the evidence for mobilization of orthopedic patients is quite good. And I was pleased to see that the Halifax group has actually updated that review fairly recently, and there is some evolving evidence that does support the early mobilization of trauma patients, in particular in the ICU, and even showing benefits such as fewer days on the mechanical ventilator. And they actually followed up nicely with their own pre-post study, obviously with a methodology that has some limitations, but their implementation of an early mobilization study, when they looked back and compared the 2 years before and then the 1 year of the intervention and the 2 years post, they actually found a pretty significant mortality benefit to their patients. So the evidence clearly is evolving, but I think that likely most of us on the call can agree that early mobilization is an important part of our care for these patients and may even actually confer a significant benefit even in the form of mortality. And ultimately, we're trying to get that patient back out of our hospital's ICU, out to the ward, so we can get them to rehabilitation, which is a very extremely important part of the patient's journey. And because ultimately our goal, as we talked about at the beginning, first few slides, is to get them back to return to life. As one of my preceptors always phrase it as, we want to get them back to being a gainful taxpayer contributing to the Canadian system. So similar to the concepts that Dr. Kreder outlined, I tried to put some of these things down on a single slide. And we really have that balance between, classically too much surgery versus not enough surgery to move the patient along. And these concepts, reading some of the stuff in the orthopedic literature, putting that in the context of some of the trauma literature, we've kind of come through this paradigm from the open abdomen perspective, safe definitive surgery, early total care, damage control, orthopedics, early appropriate care, and having to kind of walk that line, or in some ways, kind of weave that slalom course in terms of which element we're going to pick up on at which time that's going to lead to the right treatment for the right time for the right patient. And then we also have that team-based approach that needs to take into account the other injuries the patient has. What is their brain like? Do they have a drain, and do they have ongoing issues with ICP that need to be addressed? Is their abdomen open? Does general surgery need to close it up? Do they need to get the liver embolized? Do they need to help us fix the bladder so we can fix the pelvis, or do they need us to remove something so they can do something? How is that going to work, and what's the sequence going to look like? And how do we kind of progress that patient's care along as we go through this? Some overall comments that I just wanted to share and welcome to discuss with the panel is that I do think it's important to realize that not all resuscitations are equal. Whether that is in the trauma bay, or the operating theater with our anesthesiologists, the intensive care unit with our intensivists, there are some small but probably important differences in some of how these things are conducted, and then sometimes the devil is in the details. And so recognizing what's been done, what's been corrected, what's been watched, and what's being continually evaluated is important to keep in mind. Even something simple like temperature control in the operating theater. If you don't have hemostasis, you don't have anything. I think it's always important to not get the cart in front of the horse with that regard, because sometimes we can get lulled into thinking that we have that, and that can really beget a big problem. So I think it's an important thing before we move forward is to ask that question consciously and out loud of ourselves and our team. And then also when we look at the evidence that's out there, and Dr. Kreder highlighted some of this, we have to put it in the context of major advances that have occurred in resuscitation over certainly the last 3 decades, and in particular even over the last 5 to 10 years. And I've listed some of those there. And so when we're looking on the literature and what the evidence shows us, it is really important to remember some of the advances in resuscitation that have been made, and to make sure we don't overinterpret what is existing from historical research. And lastly, when I think of the care of a polytrauma patient, I really kind of think about the concept of bottlenecks, and what is it that the patient needs next? And after that happens, what is it they need after that? And what happens after that? And what can I do about the problem in front of me, but what can I do with the problem that's going to come after that and after that? And there's lots of system-based bottlenecks, which is often, the things that we like to describe, and certainly the things we like to complain about in the surgeon's lounge. But there's probably also a lot of personal practice, group practice, cultural-based elements that we might contribute to that create bottlenecks to the patient's care in and of itself. How we book those patients, what time is it of the day? What am I going to do first? What am I going to do second? How is that going to work out? And so when we're thinking about how we can optimize our patient's care, it's worthwhile to think about, are there things that we're doing consciously or subconsciously that we might be able to alter that might improve the patient's care? So thank you very much, and I look forward to the rest of the presentations and the panel discussion.
Well, thanks so much, Paul. That was wonderful, and I think an excellent, really excellent summary of a lot of the complex concepts we don't really get a good appreciation for. I think in orthopedics sometimes, and thank you for sharing all that. Now, next up, I'm just going to carry on with a brief intro here for really what we're really lucky to have her join us today. Dr. Niloofar Dehghan comes to us all the way from Phoenix, Arizona, but she's an ex-Torontonian, trained at U of T for orthopedics. We really kind of started our orthopedic journeys around the same time. As she got really so involved in COTS and led some really phenomenal randomized controlled trials in the area of polytrauma care. She's got 3 Beauvale Awards to her name, which is the top research paper at the OTA. She's going to share some interesting concepts with us for an orthopedic surgeon to think about, but not becoming more commonplace. And she'll talk to us about some of her work with rib fracture management. And so with that, I'll turn it over to Niloofar, and thank you again for joining us this evening.
Thank you so much for that awesome introduction. And thanks very much for having me. Those were some great talks, and I wanted to take an opportunity to talk about some specific injuries within orthopedics. And I think flail chest is definitely an area that is multidisciplinary and spans across orthopedics and trauma and respiratory care, and really talk about does surgery really improve outcomes and what's the latest evidence? Can everyone see my screen, I hope? Yeah, okay. So this is a flail chest, usually 3 or more consecutive rib fractures in 2 or more locations, creating a flail segment. And what's the issue with a flail chest? Well, for one thing, you get instability of that segment. You get deformity of your chest wall, especially if your whole chest has been caved in from the trauma, and there's a lot of pain. And because of those issues, a lot of patients have trouble breathing or maintaining their oxygenation, and a lot of patients require mechanical ventilation as a result. And what's wrong with prolonged mechanical ventilation? Well, it costs a lot of money. You have to be in the ICU. There's prolonged ICU and hospital length of stay, high rate of pneumonia. They have to get a tracheostomy, sepsis, barotrauma, and so there's a lot of bad things that can happen from prolonged mechanical ventilation. And flail chest injuries are not insignificant. A couple of broken ribs here and there are not really the issue. This is when you get your chest wall caved in and you get that unstable segment, which does cause a lot of morbidity. And this is a study we did looking at National Trauma Data Bank, and you can see 80% of patients are in the ICU. A quarter of them, or a fifth of them, require tracheostomy, and death rate is 16%. So those are fairly high rates of morbidity. And what's the current treatment? Well, non-operative treatment, which includes mechanical ventilation as needed. So if you're decompensating mechanical ventilation until you start to improve and can be weaned off. Analgesia, so pain control, is critically important. You can do intercostal nerve blocks or PCAs or epidural catheters, but really get their pain under control so they can take a deep breath. And that gets into your pulmonary hygiene to be able to clear the secretions, because if you can't take a deep breath, you can't cough, you can't get those secretions out, you have a higher risk of pneumonia and sepsis as a result. So pulmonary hygiene is another big thing in terms of non-operative treatment. And surgery has really become a lot more in fashion in the last decade, I would say. So certainly 20 years ago, or even a decade ago, talking about surgery was really rare indications, and very few people were performing it. Nowadays, the pendulum has definitely swung to the other side, whereas I just had a patient in my clinic today with a couple of cracked, undisplaced ribs, and somebody was trying to convince him that it should be fixed. So surgery is definitely an option, and we'll discuss about whether that really is indicated or not. So this is just a case of, it's difficult to see these on the initial chest x-ray, but even on this x-ray, if you look closely, you can see multiple rib fractures on that left side, and there's a flail segment, and the 3D recon can really be helpful to visualize exactly where the breaks are and what the location is. And so surgical treatment is relatively straightforward. I mean, it's significantly easier than doing a difficult pilon fracture or an acetabular fracture. The approach can be a bit intimidating for some orthopedic surgeons because it's not an area that we're usually operating on. But once you get comfortable with the approach, the actual fixation of ribs is fairly straightforward, and generally plate fixation of these fractures. And this is a post-operative x-ray of that patient. So what are the potential benefits of surgical fixation? Well, there's been a lot of small studies, retrospective studies. There's actually 4 small RCTs. And for the most part, studies show that potentially you can take patients off the ventilator quicker, less time in the ICU, less pain, less pneumonia, less deformity. So this is what's been driving that enthusiasm of surgeons wanting to fix rib fractures. And I say but because until now there has been minimal high quality evidence, and a lot of the studies, like mentioned, are small. So all the previous randomized controlled trials were about 20 patients in each group. They use outdated methods of fixation, and you could argue the non-operative care was significantly different 20 years ago when some of these studies were done compared to now. And this brings us to the study that we did with COTS, and it was a multi-centered study across the US and Canada, really looking at surgical fixation to non-operative treatment of these flail chest injuries. And this was done across 15 sites. It took 7 years to complete the enrollment, and the non-operative group received all the advanced non-operative care, so mechanical ventilation as needed, pain management, and the surgical group got all of that plus surgical fixation early on within the first 4 days. And our inclusion criteria, exclusion criteria are outlined there. Essentially, patient with a flail chest or significant deformity of the chest wall. And some of the exclusions are significant head injury or significant pulmonary contusion, because those patients potentially require prolonged ventilation because of their other injuries. And they wouldn't necessarily benefit from being weaned off the ventilator just by fixing their flail chest. So those patients were excluded. And we primarily looked at, the primary outcome was ventilator days. And the way we looked at that objectively is looking at ventilator-free days. So instead of counting that you were on a vent for 7 days, we would say how many days in the first 28 days are you not ventilated? Because that really penalizes people who die early on. Because if you look at ventilator days and somebody dies on day 1, then they only had 1 day of ventilator use, and that makes them look good. But when you look at the opposite, it penalizes patients who die off early. And we had multiple secondary outcomes as well. So this is our schematic. We randomized 207 patients, 99 in the non-operative group and 108 in the surgery group. What were the results? Well, the table 1, essentially, patients were similarly distributed based on their baseline demographics. On average, they had about 10 broken ribs and ISS of 26. So these are significantly polytraumatized patients. Now, when you look at time on a ventilator, ventilator-free days overall, so for all patients, patients who were treated with surgery had improvement of 2 days. Compared to the non-operative treatment. Now, this didn't meet statistical significance, and we can talk about that. Potentially, we were underpowered to show a difference. But when you look at the ICU stay, or even counting the actual days on a ventilator, there wasn't really any difference between the 2 groups. Now, we did do subgroup analysis looking at patients who came in who were intubated at initial onset compared to patients who were not intubated. And when you look at patients who are not intubated, it's hard to make them better with surgery when you look at time on event or ventilator-free days or even ICU stay or hospital length of stay. There was really no difference compared to surgery and no surgery. But when you look at patients who came in and they were intubated at the time of presentation, potentially those patients did better with surgery. So they had about 3 days less or 3 days more ventilator-free days compared to the non-operative treatment. So you can clearly see that there's a difference in terms of patients who present initially and are intubated compared to patients who are not intubated during their hospitalization. And what about complications? Like I said, all the other studies have talked about how pneumonia is better, sepsis is better, less VAP, less tracheostomy. Really, we saw absolutely no difference between the two groups, surgery and non-operative treatment in any of those outcomes, which was actually surprising. That's not what we had anticipated. But when you look at mortality, there was 6 deaths in the non-operative group and none in the surgical group, which was significant. Now, you could argue why that is, because if patients aren't if they don't have a higher rate of pneumonia or sepsis or VAP, why are they dying more in that non-operative group? And so that was definitely interesting finding. So in conclusion, this is the largest prospective randomized study looking at surgery compared to non-operative treatment. And I'm hoping this study will help swing the pendulum back to where it needs to be. I don't think every single patient who comes in with a flail chest needs to be fixed, and certainly the study suggests that, especially if you're not on a vent initially, you potentially don't benefit as much. But for the select group of people, especially those who are initially ventilated, you could potentially improve their, decrease their rate of mortality and time off the ventilator. And thank you very much for the opportunity, and I'd be happy to answer any questions. Feel free to reach out to me via email. Thanks.
Oh, thank you so much, Niloofar. That was fantastic, and I think a really groundbreaking study for a lot of reasons. And it'll be interesting as we hear now from our next presenter. And I just want to confirm that this is sharing here appropriately. You can see that now. Is that looking? It's my actual slide. Perfect.
Yep.
So thank you again, Niloofar. That was wonderful. And I think as we hear from our next speaker, Professor Hans-Christoph Pape, the concepts you just brought up, I think we'll find a home as we hear from really the person who is synonymous with the term damage control in orthopedics. And we're incredibly honored to have him tonight tell us about how to make the right decision and what how the concept of damage control has evolved. So thank you for a variety of reasons for joining us. Most of all, that it's almost 2 a.m. In Zurich. So we really appreciate your time, and thanks again for sharing with us your talk. Now can
you hear me?
Now we can hear you. Sorry, there we go.
All right. So thank you very much for the invitation. I'm really honored to be here. My face seems to be a little bit dark, but my mind is fresh. So hopefully I can tell you a little bit. And I hate to be, the person who is only known for damage control, because that's really not. It's not the only thing that matters, and it is not what is currently going on, because I'm hoping that I can show you that a lot of things have been going on. Before we start officially, I just wanted to point out the matter of communication, because as far as I understood, the Canadian Trauma Night is made up for residents and for people in training. And so what you have to do is you have to communicate with your attending on call. And a while back, when I was working in Pittsburgh, and thereafter we have done courses for polytrauma management, and they were, and then they continue to be concepts where orthopedic surgeons on one hand and trauma guys on the other hand, they come together. And so it's really important, if you are the resident on call, you have to communicate with somebody, which is your attending, and this attending is usually tired. He's usually annoyed. And so what we did is we developed an app, and we put together a lot of the information that is out there, and most importantly, trauma classification systems. And so what you can do with this free app, you can, of course, calculate the ISS, which is not too bad, but you can also calculate MES-NISA and other scores for soft tissue injuries, for head trauma and all of that stuff. So maybe that's helpful. But then it comes to reality, and you have to kind of judge the patient. And if you are a third-year resident, it can be a problem. Many people use the ISS, many people use the new injury severity score, which focuses a little bit more on extremity fractures. So if you have a combination like here with severe pelvis and then a bunch of other fractures, if you have a rapid rescue and good resuscitation, this patient will come to your hospital in a stable condition. If you have a similar situation, but this patient has insufficient resuscitation, delayed rescue, he may be borderline or unstable, especially if you know, you end up not finding the patient. At this time of the year, it may be quite cold, and so he may be coagulopathic when he comes in, and the combination of acidosis and coagulopathy, we all know it's not really helpful. And then another patient with the same numbers. So if you just transfer the numbers to your attending physician, but you don't know the physiology behind it, and you have a closed femur and a vascular injury, and you have a chest trauma with multiple rib fractures and hemopneumothorax, then despite good resuscitation, the patient, or with good resuscitation, the patient may look quite stable, but he actually is not, because we all know that the vascular injury is going to cause a huge reperfusion problem, and that hours or a couple of days afterwards can cause a lot of issues. So this has to be kept in mind if you talk about injury severity only. Dr. Kreder mentioned a little bit where we came from. So as far as the assessment of the patient is concerned, I think in the 90s, the triad of death was the golden standard. Then early total care, as far as the fracture care, was the golden standard as well. And then, you know, it's like a pendulum that is swinging. But I really don't like this idea of the pendulum, because I feel that we have made progress. So we are stepping up a ladder rather than a stupid pendulum keeping swinging back and forth. And so number one is not just about the femur, and we have summarized some of these issues in a recent publication. First of all, if you look at all the publications that look at the issue early total care versus damage control, which is not really the appropriate term anymore. And I say appropriate because I feel that it's outdated. So you have all these publications that you start in 2000 and just end at the 20 years later. And you can see that authors come to completely different conclusions. Early total care, damage control, no difference, risk adapted, whatever. And so people do this and that. But at the end of the day, what they all do is shortly after the change of the millennium is they respect the injury severity score. And so the patients that have early definitive care of their femur fracture, and notably this, I'm only talking about the femur right now. And so the femur fracture gets definitively fixed if the patient has a lesser degree of injury, and if the injury severity score is lower. Whereas the higher ISS scores they get a damage control procedure, and this is only the femur. We'll get back to this. And so if you look at the differences here, despite all the variation of conclusion that these authors had, they all have 5 to 7 points difference in the ISS, and so that means they have started to respect the idea that the sicker patient may be benefiting from some other kind of treatment. What kind of progression have we made in terms of patient assessment? So this is Rotondo's idea, hypothermia, acidosis, coagulopathy. It was called the lethal trauma triad. And there has also been some progression. This is the early appropriate care score, where pH, basic cis, and lactate have been chosen with distinct threshold levels. It was published in 2014. And if you look at the literature between 2003 and 2019, you can see that lactate threshold levels for the most part have been somewhere between 2, 2.5, some 3s, 2.2, one of them is 4, but there's a certain level. And this is the admission level that has to be kept in mind, because people were so convinced that the admission level is the way to go. But then shortly later, some other groups came and they looked at patients and did serial measurements, and all of a sudden it was more important to have a good lactate clearance. So if the lactate is high on admission and it clears after 36 hours, that's good. But we have to keep in mind that there's another patient group, maybe the ones that I showed initially, that comes in and looks pretty stable, but has an arterial injury that is uncontrolled with a severe soft tissue injury. That patient may not even have a high lactate level, but 48 hours later, you guys may be in trouble on the ICU and keeping up with this patient's coagulopathy and other stuff, and probably organ failure as well. So we are moving from early lactate levels to lactate clearance recently. And then I wanted to show you another study that we have done in our group. As you probably know, there are a total of 4 different published scales. So there was one 2005 where I was involved. It was just a random summary of published scales back then. Then Dr. Valier came and developed the early appropriate care protocol. Then they used this score that from 2005 and modified it. And then another group where I was involved developed the Polytrauma grading score. And you can see on the left-hand side, there are 4 different categories: shock, coagulopathy, admission temperature, and soft tissue injury. And so only this PTGS also used the new injury severity score. And if you look at the parameters, you can see that initially like a million gazillion parameters were used. Then we thought that maybe a few of them will be okay. And this one is the modification of this one. And then this one is has been calculated from a large group from the German trauma registry. So the one on the right and the early appropriate care score, they are the 2 ones that have actually been developed on the basis of a database. And so let's have a look at what the results are. So we have here 3,600 patients that were submitted to these 4 different scores. And what we've done, we have calculated the area under the curve for patients with acid-base changes only, so lactate. Then if you add coagulation, if you add the hemorrhage problem, and if you add the soft tissue problem, there was always a slight increase of the area under the curve. So the receiver operating characteristics became more specific. And so the more systems you get involved, when the patient is admitted, apparently you get a little better prediction of complications. And that was particularly for the late ones. So you do this early, but you can better predict later SIRS and sepsis. And so that we felt that that was pretty good. Now, if you look back in terms of the surgical strategy, this is an old picture from Ottmar Trentz, I believe it was. And so back then it was like, oh, we have to save the patient's life, and then we decide every, they get only X fixes or everything is surgically done, and then you have to respect day 2 to 5, and you never have to do any surgery and stuff like that. Well, that was in a time when immunology options were not so advanced, and we are now, I think we can be a little bit safer, and so that's why we named this situation more like a safe definitive surgery concept, where you decide, you balance out the early definitive care and damage control concepts. And in order to do that, we feel that you have to look at certain aspects. First of all, the patient comes in. You look at both physiology and anatomic injuries. Then you do your first assessment. You can assess the patient and you group him into the 4 different groups that have been well known. And then the patient, along with resuscitation, may undergo either improvement or worsening or stay like that. And then you have to decide, well, I mean, the non-surgical resuscitation, that's going on anywhere. People get volume, mass transfusion, protocols have been developed over the last 10 years, so that has improved quite a bit. And then comes the surgical resuscitation, which to my mind is one of the key aspects. And you have to figure out which is the fracture that is the most threatening for the patient. If it's, if he has a spine and a pelvis and a femur, well, if that femur has a vascular injury to it, then it may be much more important than the pelvic ring injury. And this is what you have to focus on first. So your task as an initially treating physician is going to be to find out which is the most threatening major fracture for this patient. And that's a big difference that happened. It was like fix everything, fix nothing, or fix everything and fix something. And now we are focused on the problem, and the problem is which part can be bleeding can be stopped by surgical resuscitation, which means fracture fixation, and that applies for major fractures in major vessels. And so once that has been done, the patient is in the operating room and is being stabilized. Then comes the effect of the non-surgical resuscitation, which is volume, mass transfusion protocol, and ventilation. And then at some stage, some hours later, when the surgical problem should be solved by far, then you can reassess the patient and find out what you can do with the rest of the fractures and what to do. And I believe that circulation, coagulation, oxygenation are 3 aspects to look at in order to be on the safe side, so to say. And so the concept that we have named safe definitive surgery is that you now focus on the most threatening fracture, and you try to limit and control this fracture in order to stop the bleeding in that area. So you, as an orthopedic surgeon, you are basically helping the general surgeon limiting the amount of blood loss. And then you can fix the other major fractures if number one, the expected OR time is too long, or number 2, if the patient becomes unstable while you're doing the first fixation. So that means you can always stop if you feel like, all right, the patient is flipping sides. And here are the goals. You should be able to do the hemorrhage control within 24 hours. coagulopathy, acidosis and hypothermia, the triad of death, should be reversed within 24 hours. And this is also another difference to what we thought before. We thought that inflammation is going on at least for a week. Well, there are certain patients where inflammation is cleared by 24 hours. So if you have fixed your most threatening fracture immediately, and the patient then clears his inflammatory status, then you can go on and do your other definitive fracture care on day 2, 3, 4, and 5. And you don't have to wait a full week and have, 2 weeks of ex-fixes with local infections of these patients. So we are condensing the surgical fracture care with this concept to the best. And I believe that our knowledge about inflammation, which has dramatically increased over the last few years, it has been helping us to become better in this respect. Having said that, I hope I was able to cover a big kind of a variety of aspects in a hopefully decent fashion. And I thank you very much for your attention, and thank you again for the honor to speak to you tonight.
Thank you, Dr. Pape. The honor was all ours. That was wonderful. And it was really great to see how the evolution has gone and the role you've played and where it's going to continue to go. So, I really appreciate your presentation, the presentation from all of the panelists. I think, we were going to discuss some cases that we're potentially going to talk about if people want to stick around. I want to respect the time everybody shared with us out of their evening, and I'd just like to turn it over to an open discussion. I welcome any questions for any of our panelists from the audience, and just potentially as we might be getting some people coming up with questions. I'll start with one for Professor Pape. I mean, you discussed a little bit about things like ISS and NISS, and I feel archaic here at Hamilton General Hospital, the trauma center that still, and I think most of the Ontario, at least trauma community, still communicates in ISS for mostly administrative reasons. And how do we get this new language that's really better at describing the patient into our lexicon? Does it need to start at an administrative level where there's other motivation to switch over, or does it have to come from the clinical ground up?
Well, as a rule, I think the clinician should be having the lead, which unfortunately we succeed less and less. But as far as the NISS or ISS is concerned, I don't personally think it makes a big difference. But any of these two in combination with patient physiology is important. And I think Dr. Villiers has been really showing us how lactate in general is an important aspect. And now we have lactate clearance. We have better techniques to look at coagulopathy in association with all that, and we can look at hidden hypoxia. And so all these aspects give us a much better clue about what's going on. Also, there's a group in the Netherlands by the name of Dr. Luc Lenen, and they actually look at acute neutrophil function in the patient when they come in, and they have created a predictive tool just by looking at neutrophils out of the bloodstream, which is a really interesting series of studies. And that may be helpful, because on one hand you have anatomic injuries, and on the other hand you have the physiologic changes, and these more subtle changes that you cannot see with our big coagulopathy changes. That may be an option. Just having to look at the leukocytes and see what they do and what they do secondarily. So I think a lot of new information is yet to come.
Yeah, no, I think and sorry if I'm freezing here, my internet connection seems to be going back and forth. I think it's challenges, things evolving. We've just heard from Niloofar tonight about a new injury, and we need to prioritize in this whole thing potentially. And as you talked about how do we have to identify the most severe injury causing the deformity in physiology. from an orthopedic perspective now, how do we bring, say, rib fractures into this? And I think maybe it'd be great to hear from Niloofar, you know, where do you think rib fracture fixation fits into the concept of early appropriate care, safe, definitive surgery? Is it something we should be aiming to do early on, or who should push that?
Is that a question for me?
For as you know, it'd be great to hear from Niloofar.
I can give you my opinion, no problem.
Yeah, why don't we hear from Niloofar first, and then it'd be great to hear from Dr. Pape.
Well, I don't want to give the wrong answer now because they're going to tell me I'm wrong. So I think if you are going to fix the flail chest, you potentially want to do it sooner than later. So you probably don't want to wait more than 4 or 5 days, because then you start to, especially in a patient who's ventilated, because then they start to get the detrimental effects of prolonged ventilation, and potentially you miss out on the potential benefit you could provide by limiting those complications. But you know, if a patient's unstable and they have a lot of other things going on, you obviously want to be pragmatic about it. So someone who's coagulopathic and absolutely sick, you know, you probably want to resuscitate them appropriately before you take them to the OR. But if their primary issue is their chest wall being caved in, and their primary issue is ventilation, and sooner the better. But I'd be interested in Dr. Pape's.
No, I actually completely agree with you. And I think you have to look at the point where you find that the alveoli, they don't fill up with air sufficiently, because then they will worsen and fall into sears, you know. So you have to, I think it's a balance between stability of the chest wall, of the patient's ability to inhale and exhale, and see how strong the rest of the thorax is moving. And then if this part of the thorax is not moving appropriately, and you can see that the alveoli, there's no air inside and you have to do something, I think that's the perfect time when you just help out a little bit. You configure the chest wall, then you help the patient get air into the alveoli, and then the leukocytes, they will go away, you know, they get scared.
It's you know, it's such a new area for orthopedic surgeons to be thinking about. You know, at least at our institution, it's definitely been a team effort. You know, we participated in the COTS trial, and then we contributed with general surgery. You know, Paul really drove that at our institution, and Dr. Petrosor kind of drove it from the orthopedic side here. And even now that we're past the trial, and this is still how we're making our decisions, primarily it's driven, I would say, by the general surgeons and the critical care team, I would say, who sees these patients and the issues and the challenges they have on the ventilators. And Paul, you know, how comfortable do you feel making that call? Like, you know, you talk about evidence all the time. Do you think this is you have the evidence you need now from a critical care perspective to show it makes a difference?
Yeah, that's the money question. And I think Niloofar provided some valuable information there that we've kind of been looking at and waiting to see. Certainly I will use the pendulum analogy on the new rib fracture, because I do think that one is appropriate. We've seen kind of gone from you know, selected use to, in some ways, what I call televangelism of the rib cage, with some zeal for rib fracture plating of all sorts of different indications. So I think it's nice to see that the evidence is coming online to guide us in terms of the patients that are going to benefit the most. I would say that it's nice to see the evidence start to kind of mirror kind of my anecdotal experience, and probably many as well on the call, that it certainly seems that the patients that fail from a primary respiratory perspective due to rib fractures, when they get intubated, if they get fixated fairly early, and if you're able to work with your intensive care group, because sometimes they may not have the familiarity that, you know, once those rib fractures are fixated, that patient can be aggressively weaned to plan to extubate. And it seems like those patients do quite well. The severely polytraumatized patients, you know, who's got an associated unstable spine fracture and a pelvic fracture, and they've got bilateral flail chest, and they have their spleen out, and they're in X-fix. It's hard to know exactly how much benefit they get from the rib fracture fixation in the acute setting, but certainly if it can be done, I think it seems to be of value. And as Herman mentioned, sometimes you also end up with retained hemothoraces and other issues, and so it's not uncommon we'll combine that with like a VATS, like a video-assisted thoracoscopic surgery to evacuate the hemothoraces and help with the overall kind of chest trauma management, and when we do the rib fracture plating, which may have some improvement as well from the critical care perspective.
Yeah, no, I mean, and it'll be interesting to see how things continue to evolve as more evidence comes out, and then the evidence that Niloofar shared with us tonight becomes more widespread. I just kind of changing gears a little bit, and going back to the concept of DCO and how it's evolved, we still, for our fives out and on the call, tend to ask them questions about the markers of damage control. How do you decide this versus that? And it's still, I'd say, to this day, stands as a Royal College question that we tend to think is going to be there. What's it going to take to get that off the exam? And maybe I'll ask Dr. Kreder. I mean, do you think we need to change something up at the way we're assessing our orthopedic surgeons who are graduating to take trauma call and make some decisions?
A couple of comments. So, as well, some of the trainees might not know, but certainly the faculty know, trauma surgery is very different in Europe and some parts of the world than it is here in North America. Professor Pape is a trauma surgeon. He does orthopedics, he does trauma, he, does everything. Whereas we have to be better communicators in our environment because we don't make all the decisions, we don't have all the expertise. And so it's a little bit different here. And, I would encourage anyone, Dr. Pape flashed it up at the end, but the excellent textbook that he has produced is really, I think, an excellent resource for anybody who wants to spend part of their life doing trauma work, from an orthopedic perspective or from a trauma surgeon perspective. So I think, in our environment, testing our orthopedic trainees needs to be fairly general, and we can't go into some of the nuances for everyone as a general, threshold for training. But those of us who are interested in trauma absolutely need to have a deeper understanding from all perspectives, not just a fracture fixation perspective.
All right, that's lots of important things to consider. And I think potentially some size of relief from our R5s is they're hopefully not having to remember more lists now. I just have a question here that's in our chat. It's for Dr. Pape. It's in the polytraumatized patients with abdominal and chest trauma and unstable pelvic fractures, how do the teams approach the patient? Is it first orthopedics to stabilize and then gen surge, or first gen surge? Or is it a case-by-case basis?
They do it like in Denver. They do it together. So there's orthopedics is in the room, general surgery is in the room, and they both they open the abdomen in a longitudinal incision, and then you can see, you can check on your pelvic stability. If the abdomen is predominantly bleeding, let's say there's a liver laceration or something, they can tamponade that liver. Then you can check, usually the liver bleeds more than the pelvis, but if the pelvis bleeds more and the liver is only like a tiny little scratch, then of course you will pack the liver and fix the liver, or even, pack the pelvis and fix the pelvis. If you have time, you can actually put a quick plate on. It really doesn't, kill you time-wise if you know how to do it. But the worst thing that you can do is fiddle around with the patient for 5 hours and be not able to control the major bleeding. So somebody has to recognize what is our major problem, and that needs to be addressed first. Otherwise, all your non-surgical resuscitation, all the fluids, all the whatever you put in the patient is going to be completely useless if that patient continues to bleed on the other side. So that needs to be addressed, and I think we are in a good position because all our patients get early CT scans, and so we can pick up very early on the major problems and separate them from the not so big problems.
I think that's a great just overall theme to kind of, I would say, maybe bring this all to a close, because I do want to be respectful of everybody's time and not keep you much beyond the hour that we promised. But and you mentioned it in your talk, it's about communication, and the whole problem stems from, I think, the environment we work in a trauma settings, and communication can be a challenge. when, say, you don't have personalities that get along and communicate well otherwise. So I think, the efforts to standardize communication are sort of, I would say, the themes of what we talked about tonight with damage control, going through different grading systems, and now kind of settling on a way to prioritize safe, definitive surgery, and trying to prioritize what what's causing the ongoing issues with this patient physiologically. And it stems down to communicate. And the better you communicate with your team and your colleagues, I think the more success you're going to have in caring for these challenging patients. So I think, with that, I would like to kind of close tonight's first opening Trauma Nights talk, unless there's any other burning comments or questions. I would once again just really like to thank everybody who joined in, and the panel for coming together and talking about some complex concepts and these multiply injured patients, and it was really great to hear from everybody, and I'm looking forward to the next talks in the series as we continue to have panels talking. It would be great to hear another thought from Dr. Pape.
Yeah, I just one quick comment, because I think this is another perfect example how the Canadian Orthopaedic Trauma Society sets the path for the future. Because what you are doing is you are making a number of new talks and new evenings. You focus on a certain aspect, and so people can read about it beforehand, and I think it's great. I think it's probably more valuable than a congress. It's also probably more valuable than your local meetings that you have, because you actually take the time now and you focus on this particular topic, and it's perfect. So congratulations.
Well, thank you so much, Professor Pape, and I think that's a wonderful sentiment to close the evening on. Looking forward to the next talk. It's going to be on hip fractures, and we'll bring multiple panelists together from a variety of backgrounds again to talk about some complex issues in these patients, and look out for that on April 15th, 7 p.m. Eastern Standard. And once again, thank you again, everybody, for joining in tonight, and looking forward to the next talk.
Looking forward to when we can get together in person again. Alles Gute.
Exactly. Okay. Bye-bye. Ciao.